a bead got stuck in the office. So a bead got stuck in the office and he already sent.
So good morning, everybody. Welcome to Grand Rounds. Still virtual. If you've tuned in a little bit early, you've heard the conversation between Adeera and I, and I think we have to be clear about whether we're going to have the expectation of people attending in person if they can, and that'll be up to us to clarify. In any case, it's with great pleasure I introduce Dr. Adeera Levin, who really needs no introduction. To those of you that have been at St. Paul's, she is St. Paul's, professor of and head of the division of nephrology at UBC. As you can see, senior lead integration clinical and academic networks for PHC. She has a long history of research, clinical work, and international work. And she's going to be speaking today on a topic I've heard before, but I'm looking for an update on delaying chronic renal kidney disease, new therapeutic strategies, and new hope. Adeera.
Great, thanks, Barry, and thanks to the team for showing up. So I have a few live bodies to talk to, which is always nicer than just to a screen. So importantly, So these are my disclosures, which everyone needs to always do within the context of any talk. And firstly, I will humbly acknowledge that I'm giving this talk from the unceded traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and most of you are also on those lands. But I think disclosures are often taken as a negative, but actually they give you perspective. And so I started as a clinician. I'm also an administrator and researcher. I have grant funding, and I've had the privilege of sitting on a number of steering committees and data safety monitoring boards, and also participating in a number of trials. So I think it's just important that when I give this talk that you understand who I am and where I'm from, and perhaps that helps, but I think they are all the way that we grow our opinions and thoughts. The objectives for today are for this audience. Some of you already know about the burden of kidney disease, but many of you may not appreciate the magnitude of it, and to discuss the rationale methodology of recent clinical trials in people with kidney diseases. And I think that's important because there are a lot of implications for how we can manage our patients and give them new hope and new ideas. This is an interesting slide that actually describes to you that from the world perspective, chronic kidney disease is a growing public health concern. By 2040, it will be the 5th most common cause of years of life lost worldwide. We have the dubious privilege of having increased our ranking on the ladder of bad things to have over the last 20 years. And I think that's really quite important for us. So this is something that all of us will see and take care of. Furthermore, if you look at 1990 or 2017, this is kidney disease due to a group of different causes: type 1 or 2 diabetes, glomerulonephritis, hypertension, or other. And you'll see that across a productive life age group between 40 and 70, you have an increasing number as well as different etiologies of kidney disease. And this leads to what we call disability adjusted life years or productive life years lost, which is really important. Sadly, there are low rates of kidney disease awareness and detection, even in the current era. And whilst we always say that Canada is better than the US, this is two large closed US healthcare systems with a cohort of 2.6 million people, followed over a little bit more than a decade, where albuminuria and proteinuria was measured in only 15% of patients with diabetes and kidney disease, and in only 5% of people with diabetes who didn't have established kidney disease. So that's pretty sad. And I think worse than that, and this is some work from Providence at St. Joe's in Spokane, Washington, as well as the UCLA, it's the same study. It actually shows medication use. So despite this large cohort and all of the information that we have, ACE inhibitor ARB use was only 25%, but sadly, PPI use and non-steroidal anti-inflammatory use went up in this same cohort of high-risk patients. So this is problematic. You're not on the right drugs and you're on bad drugs, and that's not really good. The economic impact in this country is massive. So we estimate about $100,000 per patient per year once you get kidney failure, which is dialysis or transplantation. Out-of-pocket costs associated with dialysis can account for up to 12.25% of patients' income. We estimate the Canadian healthcare system is spending $50 billion a year on the totality of kidney disease. And Braden Manns and others did a really interesting CPP and private insurance costs of people on kidney disease, and that amounts to about $1 billion per year. So this is expensive for the system and expensive for patients. And sadly, whilst we know that dialysis is the most expensive treatment, transplant offers some cost savings, which Matt Kaditz will talk about next Thursday at VGH's Grand Round, so stay tuned for that. We know that identifying and preventing progression is much more cost effective. And so we had the privilege in 2017 of holding in Vancouver a global kidney health forum where we identified gaps in care and research. And while we need to improve identification and understanding of causes, our really big remit is to look at, develop and test new therapeutic strategies. And for a very long time, and those of you in the nephrology world will know this, we didn't have a lot new to offer. And so developing novel therapeutic interventions and increasing the quality and quantity of trials is really important. So up until recently, what we had to offer the world was control your blood pressure, RAS inhibition, and A1C control if you're a diabetic. And those were the three cornerstones of therapy. And this is based on good data from, sadly, quite a while ago, which are trials of RAS inhibition in people with type 2 diabetes and albuminuria, and that demonstrated a reduction. And this is placebo versus irbesartan. But in both of those mega studies, which are done in 2001, or published in 2001, there was a fair amount of residual risk. So your risk reduction with those medications, this is ARBs, was essentially 16%. Right, so that's nice, but it's really not good enough. And there's a certain amount of problems with RAS inhibition. First of all, many of you will know that they have limitations. Some patients just simply don't tolerate them, so they don't even get that 16% residual reduction. But it doesn't protect against cardiovascular events in this population, importantly. There were no benefits on mortality. The whole of those studies were driven by delay of dialysis. And so while it's really nice to say that we have these risk reductions and they're additive, people with diabetes, especially, and those with kidney disease, remain at very high risk for kidney and cardiovascular events. And so that brings us to the story, which has really changed clinical practice tremendously, which is the SGLT2 inhibitor story. And I'm going to go through very high level the studies, the design, the results, and why it's impactful and some of the downsides, not just of SGLT2s, but other new therapeutics. Check in. Am I speaking too fast? Okay. So these are the new classes of drugs. They're called the flozins to the patients. There's Cana, DAPA, and EMPA, and there's a whole bunch of others, and they just keep coming. But suffice it to say that they impact the SGLT2 inhibitor in different ways. There are type 1 and type 2 receptors, and they can either block one, some, or different. Nice to have a little bit of history and physiology. The florozins are actually a natural compound, first isolated from the bark of apple trees by French chemists in 1800, and it induces glycosuria in dogs, and it was a way to study weight loss, glycosuria, and thirst, and induce diabetes, if you will, in dogs. And that was where it was first found. And nobody knew how it worked. And then Robert Crane in 1960 hypothesized on the back of a napkin, so the story goes, what receptor must exist in the kidney for this compound to work. So it blocks the uptake of glucose so that you get this glycosuria and subsequent effects, which we'll talk about. Just interesting to go reflect on the compound followed by the how might it work and then what. So they improve, SGLT2 inhibitors do a lot of different things, and I'll go through some of the data, but it reduces albuminuria, it reduces the hyperfiltration that occurs in the kidney, lowers sugar in those who have a GFR greater than 45, reduces ECF volume contraction, accounts for some of the inflammation that is part of the disease progression, helps you lose weight, mitigates GFR decline, attenuates ischemia, lowers blood pressure, and probably attenuates fibrosis. So it's a magic drug in many ways, but I thought it'd be really important for us to go through how we got here. So over the last 5 years, we've had an accumulation. We start with cardiovascular outcome trials, and then more recently have 2 and soon to be a 3rd specifically designed kidney outcome trial. Important for us in nephrology because most of our studies are like, oh yeah, we'll think about the kidneys after, not primarily, and so importantly. And then there's the heart failure studies as well. I will not bore you with the details of all of them, but I thought it'd be nice to highlight some of the key things. So in the key SGLT2 inhibitor trials, minus EMPA, because it's not published yet, you'll see very large numbers, first of all, but you'll see that the mean age is between 61 and 62. The follow-up is around 2.5 years. Only Credence and DAPA have people with lower GFRs and heavy proteinuria, as you can see in this slide. And almost all of the studies have tested these medications on a baseline use of RAS blockade. And that's important because that's the evidence base that we started from. So Credence, which was the first kidney outcome study, is canagliflozin at 100 milligrams in people over the age of 30, with over 4,000 people randomized, GFRs between 30 and 90, and urine ACRs between 3 and 56 in our numbers, who all had diabetes with reasonable but not perfect control, and most of whom had pretty good blood pressure control, reasonable A1C control, and almost all were on ACE or ARBs. And what you can see here is an impressive 30% reduction in all the kidney outcomes, 20% reduction in 3-point MACE, cardiovascular death and heart failure, and all-cause mortality was not statistically significant, but in the same direction. And that may have to do with the kind of people that were enrolled in the study, as well as the fact that it was stopped early for efficacy. DAPA included a younger age group, a slightly lower GFR, less than 25, a slightly lower urine ACR. Now, a third of the patients are actually, or 2/3 of the patients do not have diabetes. Sorry, 2/3 of patients have diabetes, a third do not. And that's important because it becomes the largest non-diabetic SGLT2 study until recently. Again, most are using ACEs and ARBs, and again, good blood pressure control, and similarly excellent reduction of now almost 40% in kidney events, 30% in cardiovascular death and hospitalization for heart failure, a mortality benefit in this group of patients. And the 3-point MACE was the only one that wasn't significant, but again, in the same direction. EMPA just got stopped due to efficacy. And so proudly, I think there was a large Canadian showing and a large BC showing of patients enrolled in the EMPA study. Again, this is patients greater than 18, and interestingly did not have to have diabetes. They did have to take an ACE or an ARB. Now the GFR cutoffs are between 20 and 45, no proteinuria cutoff. So this is including non-proteinuric kidney disease, as well as proteinuric kidney disease and more preserved kidney function. Same endpoints. None of us have seen the data, but and for those of you that haven't been involved in clinical trials, when you stop due to efficacy, it's because it is irresponsible and unethical to continue to randomize people or follow them if you've shown benefit. It's not fair to the placebo group, and that's why you stop. And I think it's important to recognize that it's never taken lightly by the DSMB. It's a very big deal to stop a trial early, and so they have to be very confident. So I think that's really encouraging. We'll see those results in November, I believe. So the kidney benefits of SGLT2 are really important for us as nephrologists, but also for all of you as non-nephrologists to realize they are independent of A1C. How you impact A1C is not how the drug works on the kidney to protect kidney, and that's really important. So you're not starting it for glucose control, you're starting it for disease modifying. So both in Credence and in DAPA, irrespective of your A1C or irrespective of the fact that you did or did not have diabetes, you see the same effect. And that's quite important. It's safe when you look at renal-related adverse events, acute kidney injury, and hyperkalemia. We could talk about the mechanism of why this all works like this. You actually have favoring of SGLT2s in a number of large trials of CANA, DAPA, or EMPA across all GFRs. Acute kidney injury is something that many of you know I'm really hot on avoiding, and so all of the studies have demonstrated an improvement in acute kidney injury. Now, why that is may be interesting and difficult to tease out, because it may be that you get hospitalized for heart failure less, so you're not getting DI and you're not getting unstable, that your edema is well controlled, so you don't get added in additional medications. And various reasons may be why you avoid acute kidney injury. Nonetheless, that's an important thing to note. Other safety signals, and this is important, especially at a lower GFR, you don't induce hypoglycemia. There's no signal for anything else bad. Yes, if you are a type 1 diabetic or have an intercurrent event as an insulin-dependent diabetic and don't stop your SGLT2, you have a very high probability of having DKA. That being said, I want you to look at the number. It's 10 out of 5,000. It is not a common event. it should not necessarily be the reason that you don't do it. And genital infections, yes, they are they are higher, but again, these are treated and nobody stopped the drug because of that, and they are treatable. So the totality of the data would suggest that SGLT2 inhibitors protects the kidney with and without diabetes. And this is just an important slide, and soon we'll be able to add EMPA to this. But I think it's important for us as a community of people looking after people with different levels of kidney function to appreciate this information. And so does SGLT2 work at lower eGFR levels? And that's one of the big questions, especially for those of us in kidney clinic. So in DAPA, when you looked at the risk of the primary outcome, it seemed to hold irrespective of GFR stage. So that's quite important. So it doesn't matter when you start it. What I also should mention in that all of the studies continued the drug all the way until the person's achieved an outcome, be that dialysis or transplantation. They were not stopped as people progressed. And actually in DAPA, they continued even when they were on dialysis. This is the decline, whether you're stage 2 or 3 or stage 4, you'll see that the delta decline is higher the more kidney function you have, and it's lower the lower your kidney function. And that's important because we're always worried about starting things late, but in fact, you don't get as much of a drip. And then importantly, all studies show this, you get a flattening of the curve, whereas the placebo group continues on. And they're just the numbers, the acute and chronic slopes, and the total slope over time is different attenuations. And this just shows you again in 3 different subgroups in the CANA group, the number of months it takes since randomization to get to steady state. And this is also important for us because in the lowest GFR, you appear to get the benefit earlier at 8 months versus 11 months, the higher GFR, and 14 months, the higher GFR. So that's also important in terms of managing people's expectations. They do not lower A1C at lower GFRs. It's because you don't get the glycosuric effect to the same degree, and that's important. So don't start it in people who have diabetes to lower their kidney function if they have to lower their sugars if in fact they have lower kidney function. So this is a nice thing from some colleagues, Meg Jardine and Dr. Kang in Australia, looking at an evidence summary of the cardiovascular and kidney benefits. And I don't think anyone has to be a statistician to see that everything is essentially left of one, which means it favors SGLT2s. And this is what SGLT2s do in addition to some of the other drugs that we'll talk about, right? So they actually induce sodium diuresis. They improve kidney function and the cardiorenal crosstalk. They reduce preload, afterload, and left ventricular wall stress, which is important from a cardiac perspective. And full disclosure, I will not talk about all the cardiac trials, but they've all shown exactly the same thing that I'm going to show you with the kidney trials. And they reduce interstitial edema, which, as you know, is not good for any organ function, be that your lungs, your gut, your heart, or your kidneys. And so important from that perspective. And they do all of this, whereas all the other medications, many of which our patients need to be on, do some of these things, and they work in concert. So this is the thought, is that they alter interstitial and total body volume, alter metabolism, which is really important, so you get an anti-inflammatory metabolism, and improve sodium balance. All of these things lead to a number of changes in the cardiorenal axis, including a reduction in dysrhythmias, which again might be multifactorial, a change in cardiac function. Arterial wall compliance is enhanced, albumin is reduced, and therefore you get this very nice change, but improvement in both cardiovascular and kidney outcomes, which have been shown in all the trials. So if I were the sort of interim fact here is that all of the studies, whether they're diabetic or those with kidney disease or those with heart disease and any combination thereof, have demonstrated an improvement in kidney, cardiovascular outcomes, and heart failure admissions. Multiple of the RCTs are quite concordant in over 40,000 patients. There's a lot of biological plausibility and mechanisms in recent publications, a number of them demonstrating some really quite fascinating things that SGLT2s do to metabolism. We have, from the totality of data, identifiable patient profiles, no independence from hypoglycemic, no increased AKI. across increasing categories of GFR and urine ACR, and they seem to be strong. I haven't shown you that data, irrespective of whether you do or don't use an ACE or an ARB, and that's important because, as I said, not everybody tolerates those drugs. But I might actually also highlight that all of these studies used fixed doses of SGLT2. This was not a targeted, ratcheted up to achieve a blood pressure or achieve an X or achieve a urine reduction in urine ACR. They were all just fixed dose go. Much as you'll remember was the same as HOPE, which was ramipril fixed dose. Much as you'll remember was also all of the mineralocorticoid studies with spironolactone and heart failure. They're all fixed dose. And I think there's a message there. But we'll get back to that. So here's the range of GFR. So cretins had the highest GFR and the highest urine ACR. DAPA dappled further, and then EMPA that I just talked about that just finished was even lower. So we're increasing the spectrum of the kidney outcome specific trials of fixed dose, no targets on top of best care with international populations, right? All of these studies were international, which is really quite great from a generalizability perspective. And this is what it looks like. If you actually take the average change in GFR of a diabetic, which is about 5 mils per minute per year, and you think that 10 is a bad place to get to, and you modify that as you did in the study to about 1.58 for years, you just bought somebody 13 years off getting to that gray zone of 10, where you may or may not go on to dialysis depending. However, it makes a really big difference. And here, the estimated cost of a 13-year savings for delay of dialysis would be about $500,000 or $834,000 for one person over those 13 years. And so these are important things when one is trying to make arguments to pharmacare, as I did earlier today. Now, CKD progression, it can't be that perfect. It's driven by it's kind of complicated, and there's a lot of different metabolic, hemodynamic, and inflammatory and fibrotic factors, and I'm not going to bore you with all the detail, but it's important to remember with all of our organs, whether it's heart or lungs or kidneys, it's the same basic 3 things that impact fibrosis and progression. And so we know that there are a number of these things that are going on and a number of different ways to mitigate those. No, you don't have to read it, but yes, I think you all once learned this. So this is the renin-angiotensin-aldosterone system, and it's pretty complicated, but it actually all roads with over amplification lead to fibrosis, kidney disease, heart disease, and even malignancies. And I think it's quite important that we remember the complexity of the renin-angiotensin system, and also know that drug classes have been developed to try and mitigate that, whether you interfere with enzymes, receptors, or whatever. There are various medications that are available that actually interfere with this particular axis, which is complicated. And so I thought it's worthwhile, whilst not yet available in this country, but likely soon to be, to understand the difference between this new non-steroidal MRA, finerenone, and the old ones that we're all used to using, spironolactone and eplerenone. Basically, they have very different structures. They have high potency. They have different kinds of selectivity to the mineralocorticoid receptor. They may or may not penetrate the CNS. The important thing about finerenone is there's 0 signal in phase 2 and now 3 studies that there's any gynecomastia whatsoever. The hyperkalemia is much less finerenone, and I'll show you that data compared to our usual suspects of spironolactone and eplerenone. And importantly, there's a balanced kidney heart uptake, if you will, with finerenone versus the other 2. The half-life of these agents is also very different, with finerenone having a very short half-life and spironolactone and eplerenone, as you know, having longer. In preclinical studies, it's really interesting to see that this new agent actually reduces fibrosis and a whole bunch of inflammatory markers. And I think that that's important because it helped to what's the word I want, propagate the excitement around this class of agents in terms of a delay of progression. So there is something called the finerenone program, and for reasons that will remain unclear to me, someone was very obsessed with music, and so all of the studies are called Fidelio, Figaro, and then interestingly designed so that you could have a meta-analysis with individual data called Fidelity. So the Fidelity is a pooled analysis, which I'll come to, but wanted to give you a bit of background. And also for those of you that are interested in clinical trial design, this was very cleverly done. So Fidelio is with diabetic kidney disease. Figaro is with diabetic kidney disease, but the outcome measures are kidney here and cardiac here, designed almost identically to address this population of people with urine ACRs that are elevated irrespective of GFR down to a GFR of about 25. And so important group of people at super high risk for all of these events. So this shows you the Fidelio study design. So this is 13,000 people. The primary outcome is kidney composite followed by cardiovascular composite. People are randomized to 10, or if tolerated without a certain number of things, they go up to 20. The eGFR is 25 and the ACR is 30. So that's a group of people that we all see, and the median follow-up is 2.5 years. Figaro is quite similar. It's 7,000 now. It's a primary heart outcome followed by a secondary composite kidney outcome, and very similar inclusion criteria. So like all studies recently, this is quite impressive that on top of best care, this drug seemed to reduce the incidence of the primary kidney failure with a sustained decrease in GFR from baseline or kidney death, whichever came first. And you can see that the lines separate here, interestingly, at around 24 months, so 2 years of therapy. If you look at all the different components, everything is to the left favoring that medication. And the question that we're all nervous about is, how did the change in serum potassium over time occur? Well, it was a 0.23 millimole at month 4 that was sustained. And that's important because we're all a little bit nervous about this. To get into the study, you had to have a K of less than 4.4 at the time of randomization. However, in the run-in period, there were people that did enter with Ks of 5, and still very little changed. So I think importantly, this was across all groups, and I think is reassuring to the clinicians. So the pooled analysis, which is Fidelity, because the studies were designed as mirror images just with a different primary outcome, you can actually put all of that together in a patient level analysis across this huge spectrum of GFR and CKD and look at everything together. And I think this is quite exciting and hasn't yet been done. So here's what the 13,000 people that got this medication looked like. 65 years old, predominant male, which is a whole other conversation that we can have, a duration of diabetes that most of us are familiar with. A1Cs quite well, good blood pressure control. Half of them had cardiovascular disease. Small number had a history of heart failure, and the median K was 4.4. What's lovely about this pooled analysis is that almost 900 people were on SGLT2s at the time of this study, which is, it was never designed to test this problem, but really nice to have that much data in rigorous fashion with the two agents. And so you have 13,000 people that we can actually look at. And again, look, 100% are on RAS blockade, right? Which actually speaks to, again, the cornerstone of current therapy. So this is the pooled analysis, and it significantly reduces the risk of the cardiovascular composite outcome by 14%. So that's non-fatal MI, CV death, non-fatal stroke, or hospitalization for heart failure. Number needed to treat is 46 after 3 years, not bad at all. And if you look at the GFR outcome, then what you see here is a hazard ratio of 77%, number needed to treat is 60. So again, a very powerful on top of best therapy in a group of people at risk. And so the safety outcomes were quite nice across all groups. There was very little difference, and worsening kidney function did not occur, and acute kidney injury was not any more prevalent in placebo versus the finerenone group. The hemodynamic effects of this non-steroidal mineralocorticoid are not the same as the RAS blockade or SGLT2s. Preclinical data suggested that a combination of the two agents might have a benefit. And this is some information about cardiac and renal fibrosis in animal studies, looking at the combination of control, placebo, EMPA, finerenone, and the combination. You see a major reduction and a change in survival. And so they were able to look at this pooled analysis for the cardiovascular outcome off and on SGLT2, and heart failure off and on SGLT2. And again, you'll see that there seems to be a signal for, if you're on SGLT2, it may have a combined additive, if you will, effect in terms of these outcomes. which would be quite consistent with the heart failure data with RALS and the older studies that a small dose adding of something improves cardiovascular outcomes. And if you look at the renal outcomes, the numbers are very, very small here. However, there's only 36 people on SGLT2, but nonetheless, you're still getting a similar signal direction. And there are studies now being planned to look at this much more formally. I think that's kind of exciting for our patients and for us because we want to make sure that we have a strong evidence base on which to change our outcomes. And so what we know is that there's a lot of very complex mechanisms in the progression of kidney disease in general, and that interaction of diabetes, cardiovascular disease, and kidney disease and all of the various combinations is really mind-whirling. We know that activation of the renin-angiotensin system is central to a number of different mechanisms of progression, and that it looks like the non-steroidal MRAs actually on top of whatever best therapy is today actually works. And interestingly, you don't get the median change in blood pressure is about 2 millimeters of mercury, and the minimal change in potassium levels, as I showed you, was about 0.23. And when people have done the analyses, the attributable changes in outcomes are not related to the change in blood pressure nor the change in potassium. And there's a lot of questions, of course, that are ongoing, which is what happens if you can't use an ACE or an ARB? Can you still use this? What happens if people without diabetes? And studies are currently being planned. There's a suggestion of benefit, but how real is that? And what happens if your K is a bit higher? Nephrologists, as you know, have a tolerance for Ks of 5.5 and lower. It doesn't fuss us. However, I don't know that we'd all be that thrilled in starting these medications quite yet. And what happens at the lower urine ACR and lower GFR? So we still have some questions to answer. So if you delay progression of kidney disease, it's through blood pressure control, metabolic changes, including glycemic control, antiproteinuric agents and antifibrotic agents in that respect in terms of RAS blockade. You know, we've certainly demonstrated the impact of a multidisciplinary team spelt wrongly, which includes a nurse, dietitian, social worker, and pharmacist that really does change people's adherence as well as understanding and self-actualization, and really does reduce and delay progression of kidney disease, allowing for better decision-making and other things. We, rightly or wrongly, perhaps have to modify the frequency, but regular blood work and urine ACR monitoring is certainly the cornerstone of both feedback for the patient as well as for the team. And regular intervals are really important for education, navigation, and surveillance purposes. And I think that those are all important in delaying. But now, I think we can actually do a bunch of things differently. And if you think about the new paradigms and you take what we're trying to do, and I parenthetically should have said that not only is dialysis costly, but it's also costly to the environment. And one of our colleagues in Victoria gave a lovely talk last week on planetary health and the amount of greenhouse emissions that dialysis itself actually costs, let alone all of the waste products, et cetera. So there are many things that would be helpful in terms of delaying progression. So if you try and address the inflammation and fibrosis, the hemodynamic drivers of progression, and the metabolic drivers, then you start with an armamentarium that includes now a lot of different medications that both protect the kidney as well as the heart. And we know that there's important interaction between those two. And so I think this is a new paradigm that has a very large evidence base at the current moment. And maybe just to end, we'll talk about the changing landscape in nephrology, which is really quite exciting because for many, many years, we didn't have a lot of studies. We had this nothingness from basically 1990 to 2015 or 16 when we got tolvaptan, which is specific for polycystic kidney disease. But now we have a number of other things, potassium binders, SGLT2s, mRNA, non-steroidal MRAs. And so things are increasing. These are approvals in nephrology in Canada. So the why the non-steroidal MRA is not here is because it has not yet been approved, although it is in US and Europe. We've actually developed some concordance of definitions for clinical trials that allows us to compare the different trials and learn from them. And this was the last meeting before the world closed in January of 2020, where we created a series of very specific and translatable to all health environments definitions for kidney failure for clinical trials, which is quite important. And there's a kidney precision medicine project, which has been started in the US, which is really fantastic. It's clear that for many years, We've been hampered by the fact that none of our animal models replicate real human disease phenotypes. We don't have a good molecular understanding of the variety and the variability of human acute kidney injury and chronic kidney diseases. So we haven't been able to look at human targets, and we haven't had a lot of biopsy tissue. And so this initiative is actually to look at an ethically and safe way to get kidney biopsies for people with what we call good old-fashioned diabetes and hypertension, good old-fashioned AKI, create a reference kidney atlas, find disease subgroups and stratify the patients, and then look for cells, pathways, and targets to get novel therapies. For those of you that are in the cancer world or know about the cancer world, this is what cancer did 20 years ago. And that's why they're in a very different place in terms of taking care of people and understanding the nuances of different therapies and stuff. And so I think the notion is to improve outcomes for patients with kidney disease by improving our understanding. And so as biopsies are safer and as we understand the value for prognostication, not just for research purposes, it may be important to think about this, and we can talk about that. We all know as clinicians and as researchers that there's huge variability in outcomes. There are people that respond to drugs and people that don't. There are people that get all the bad side effects no matter what you give them. And there are people that get nothing. And this isn't even predictable. It's not like if you're a responder, you won't get adverse effects. And if you're a non-responder, you will. It's actually quite variable. And I think that's important for us to recognize as we try and aim towards much more patient-centered outcomes. And so really understanding that these three individuals who have exactly the same GFR, but are different ages, different backgrounds, and different causes of their kidney disease will actually represent different phenotypes. And by understanding their conditions better and more deeply, be that with clinical data or with omic data, I think we were going to offer them different kinds of therapy at different points in their trajectories. And there's a big data, big science movement in nephrology, which is really exciting, where we actually integrate the data from multiple sources to improve patients' outcomes. And this is, yes, you can get blood and urine, but you can also get both indirect and direct measurements of fibrosis and inflammation from biopsies, as I talked to you. There are a number of different platforms now where you can actually understand, embed that in new knowledge, and then through very sophisticated, way above my pay grade, computational modeling and analyses, you can actually get insights into targets, but most importantly, therapies. And so we imagine that using what we know now, with all of this new proteomics and transcriptomics, we can get these molecular signatures, learn about things, and then have not only new targets, but actually better prediction. So who will not progress, who will progress, who would then benefit going into a trial, or alternatively getting a therapy or not getting a therapy. So people talk about precision medicine like it's something new. It's actually been around for a long time. We were always taught that you make use of all of the information available to you and the team about the patient to make a decision about a treatment option. We still take histories and do physical exams and do blood and urine tests. If you take also biopsy samples and molecular diagnostics and try and incorporate that with all the omics, then I think we get closer and closer to precision medicine. But it's all personalized around what we do know in the moment and what we're hoping to learn. So in the current state, we now have more and more biomarkers. We're understanding genetics of kidney disease better and things that promote progression. We're understanding the value of biopsies, as I said, for both diagnosis and prognosis. There's a whole armamentarium of people looking at novel study designs for complex interventions, platform trials, adaptive designs, and cluster randomization, which is a way to move the field forward. And it's very much what cancer has done. And part of the reason why they've learned so much is perhaps because they've got this, have taken this on a lot earlier. And there's a lot more therapeutic strategies. So if we're trying to change clinical practice, I think it's really important for clinicians, but also for us to explain to our patients that there's not just new data, but it's truly new hope. The studies in diabetic and kidney populations have been designed really well. I think their results and conclusions are quite robust. And why they're impactful is that they actually are truly disease modifiers. So what you're not doing is you're not saying, I'm going to fix your blood pressure, I'm going to fix your blood sugar. You're saying, I'm going to change the course of your kidney disease. That's a much easier sell in terms of implementation, as well as in terms of impact for patients, because patients don't care if their blood pressure goes up or down because they don't feel it, but they care that they're not going to need dialysis quite as quickly. So what I've tried to do, and I promised Barry it would be 40 or 45 minutes, and I'm almost on time, is to try and give you a sense of the burden of kidney disease and how big it is. That there are some cornerstones of therapy that we've been using for a long time, but there's such a huge amount of residual risk. And we are beginning to identify those who benefit from the newer agents, and how you best enable best practices is another bit. But I think ideally we have an ongoing dialogue about all of this, and stay vigilant and patient focused in terms of who will do well with what and what their goals of care are, so that we actually get it right from the beginning, and encourage people to be enrolled into clinical trials, because this is how we learn. And they also get better care, as you probably know from the good old-fashioned Hawthorne effect. So I'm going to stop there, if that's okay, and happy to entertain any questions.
Thanks, Adeera. Wow. I'm sure there's lots of questions. If you want.
I don't know, I was like, wow, good or wow, bad?
Oh, wow. Wow, good. You can use the chat, or you can, are there any specific questions that you want to address to Dr. Levin? And I'm sorry, I can't see people, so direct.
Probably just unmute yourself. Or not. Okay, yeah. Go ahead. Go ahead. There's somebody in the audience. I'll start with that because I can see them. Go ahead. Sure, yeah. You have to push the button so everyone can hear you.
Does that work?
Yeah. I think so.
Yeah. So I had two questions. Well, the first one was about coverage for SGLT2 inhibitors.
Yep.
Yeah, my understanding is that EMPA is covered for diabetes with some modifiers, and DAPA for HFrEF and some modifiers, but I'm wondering for kidney disease, at what point will we have coverage?
We hope sometime in the next 6 to 12 months. Pharmacare has a process, I'm told, and had a long conversation with the process at Pharmacare, and how it's not able to be expedited for any reason. So at the moment, it will be fully covered. Now, remember that there are ways for people with diabetes. Well, for diabetes, you can get it, and for heart failure, you can get it. That's a lot of the population of BC that also has some kidney disease. For kidney disease specifically, it's not yet there as an indication, but coming soon. And soon also, a lot of these drugs will be generic, so the price will come down. And interestingly, we had this conversation amongst the nephrologists. When you ask a patient, is it worth it to you for $500 or $1,000 a year to delay dialysis? You'd be surprised. A lot of people will, in fact, over time, it's not inconceivable. Now, for the poor, that's a different conversation. But I think for a lot of people, they're prepared to do that. Like they're going to the aromatherapy store and various other health food stores and paying lots of money for things. So this is, it needs to be much more available. Other provinces do have it available, but stay tuned soon. And your other question?
Yeah, and my other question was, I saw that you were talking about studies where people continue SGLT2s into dialysis, but for you, like at what GFR would you be comfortable still starting SGLT2s, or like?
Well, funny you should ask, because I went through it. So I just started some with the GFR of 15 to 17. Why? Because I don't have anything else to offer him. And going on to dialysis is something that he won't do well with. And if I can buy him 3 more years, and I showed you that graph, like the dip isn't nearly as great the lower your GFR. So that's actually reassuring. And he's in a very secure environment with our kidney care team. So we're not going to miss anything. And if you go from 17 or 15 to 14 or 13 and stay there, that's better than saying, oh, I'm just watching you go down year on year. But again, that's in a very protected and very safe environment. So I'm not suggesting that all of us go out and start it just no matter how low. But I think and it's a conversation with the patient, right? He understands that, the risk is that he'll understand the number will go down, but not to worry, right? And then we'll see what kind of benefit he gets. Or she.
I have a couple of questions in the chat line. First of all, Dr. Munt makes the comment that the use of empagliflozin in 25 milligram tablets and a pill cutter is half the price. So that's
Yes, I was going to suggest, yes, so that we have also found that any drug that you can give them the right dose by, because they're all cost the same, whatever the pill size, you get the highest one, get them cut in half or a quarter, and it's half the price for the patient. So the modeling that that's really important to know from a very practical perspective. Thanks, Brad.
And the second is a question from Dr. Barry Chan. Have you noticed a change in the SGLT2 prescription pattern for CKD beyond nephrology? So in other disciplines, and are we underprescribing given the current funding paradigm when possible?
So short answer is yes, we're underprescribing, although I think there's been an increasing uptake in the nephrology community across the country, but still not 100%, really marred by the fact that it's not so easy. You've got to fill out extra paperwork. And if they're not diabetic, you've got to get them to pay for it themselves. So I think until we fix that, that's an issue. So I think, so there has been a slow increase. There are a number of different studies that are being planned to look at increasing uptake and patient adherence, but we have to remove the barrier of the cost first. And I hope that answers. Yeah.
From Cheryl P. at Ravensong, if there's a time, can you comment further on the safety of these drugs, the SGLT2 drugs? Now, it can be challenging for this particular person to follow up with blood work and the blood pressure checks, etc. You did allude to safety, but maybe you could just repeat that.
So it's very safe. The drug class is very safe. In fact, things that you have to worry about when you start an ACE inhibitor, like hyperkalemia, don't occur. And we know the kidney function goes down, so you don't need to check it because you'll just confirm what you already know is going to happen. So we're not advocating for rapid follow-up once you start the medication, which would make it easier. The change in blood pressure is what you want. The change in weight is usually what you want. And the change in edema is usually what you want. Initially, when we were starting out using these drugs, we were saying that you should have the diuretic, but it turns out that you don't need to do that until you demonstrate hypovolemia, that most people it's adjunct and you don't need to necessarily preempt it. They should be easier to use than ACEs and ARBs. And one of my fantasy studies is to take people that are intolerant of ACEs or ARBs or are on ACEs and ARBs with a large diuretic and a potassium binder and see if you add in SGLT2 what you can deprescribe and still get the same effect, because pill burden is also another thing that I'm a bit worried about with this patient population and how we can mitigate against that. So these are some creative other thoughts that we might think about from a patient-centered perspective, but developed and tested this way. Yeah, sorry.
Any other questions or comments? I have a question. I mean, with the armamentarium that we have, if you were introducing a strategy, a patient who has a GFR of 40, and the first time you see they present non-diabetic and no heart failure, present to the clinic, do you have algorithms that you are suggesting implementation? Because pill burden is one thing, but I can't imagine even the safest drug is if you introduce 2 or 3 at the same time wouldn't cause a problem.
Yeah, I'm not quite sure that I understand the question, but I mean, so the other big subgroup that was in DAPA were IgA nephropathy, another group with whom we have very little to offer. So that group seemed to do very well with this drug. So I have a young person with IgA nephropathy, GFR of 40, 45, proteinuria, and this would be an outstanding drug to put them on from the beginning. I don't think we've quite gotten to the algorithm stage yet in nephrology, but it's something that I think we would work towards. And the recommendation from the Heart Failure Society, as well as the Diabetic Society, to start SGLT2s quite early on in the armamentarium, not to wait until low. And the current evidence-based recommendations are proteinuria irrespective of GFR, or heart failure irrespective of GFR. So I think those are important. That gives it a much wider berth, if you will.
Thank you. Any other questions or comments? If not, Before I thank Dr. Levin, just to mention next week, for those of you that have a keen interest in nephrology, and even for those of you that have a moderate interest, we're going to hear nephrology from Dr. Kaditz, Money Talks, Health Economics, and Kidney Transplantation Policy in BC. Thank you, Adeera. It's always a great pleasure to have you. I always learn a lot, and you've challenged all of us to think about this a bit differently. So thank you very much for presenting.
You're welcome. Thanks for those of you that came. It's a whole new concept.